Hey guys, it's once again Dr. Russell Linville. I'm happy to be back teaching you for a third time here on the post-operative ankle for this lecture. And compared to the knee, the post-op ankle isn't nearly as in-depth. With that said, there are some special considerations and things that you need to look out for, just as we did in the knee and in the elbow and all that stuff. So without further ado, let's kind of get into this, and then please, as you have in the past, take some notes and ask some questions regarding this material as we go along. So our objectives: I'd like for you guys to gain knowledge in common foot and ankle pathologies and the surgical interventions that are used in the treatment of these pathologies. We want to facilitate discussion and practical application of treatment strategies following surgical intervention of aforementioned pathologies. We want to discuss special postoperative considerations, including weight-bearing status, immobilization, and ankle range of motion restrictions. And then we also want to practice our manual therapy techniques for the foot and ankle, including joint mobilization, manipulation, and soft tissue mobilization. And it's going to be a big component of our lab time this Thursday here, May 12th. We're going to spend some time going over joint mobilizations as well as manipulations of the foot and ankle complex, as well as the tibiofemoral or tibiofibular joint, both proximal and distally. So we'll get into that. Surgical procedures: there's endless options and combinations of operations that can be performed on the foot and ankle. This is a very, very complex arrangement of bones, tendons, ligaments, etc. All the surgical operations are looking to do is to restore normal anatomy as best we can, and this is such an adaptable area of the body, meaning it adapts to stress placed on it, to different surfaces, to uneven surfaces, to proprioceptive responses. It's a very, very adaptable joint. And there's so many joints in the foot and ankle complex that it makes it malleable, right? Changes given to whatever surface it's on. But it's kind of like an orchestra of tension and relaxation and things to make all that happen. And when there's something wrong with that, if it's too tense or too lax or that sort of thing, then we start falling into our injuries, or if we get those overuse injuries, like when runners get stress fractures and things of that, that's when we start getting into trouble with the foot and ankle. So as far as surgical operations go, we can have our bony operations, our tendinous, and our ligamentous. There is also some nerve releases and things like that. We won't dive into much of that. For our sake, we're going to go over these operations highlighted in red, and the reason is because those are probably your most common injuries. But let's quickly go through some of these, especially the ones that we're not covering deeply. But if you look under bony, we're going to go over ORIF procedures. Those are quite honestly the most frequent things you'll see. The open reduction internal fixation for fractures. A pylon fracture, it used to be known as a plafond fracture, and essentially it's a fracture through the talocrural joint, which actually disrupts some of the articular surface at the distal end of the tibia, I guess, or the talus, but it's called a pylon fracture. Our arthrodesis or foot fusions could be an ankle fusion, we'll get into that, and then of course total ankle arthroplasties. For tendinous, we have our Achilles tendon repair and our peroneal tendon repair. We'll dive into the Achilles tendon protocol and that sort of thing today, and then our ligamentous injuries. So these are what happens when you sprain your ankle severely, right? Everyone's sprained an ankle. Lateral ligament reconstruction or repair is usually due to a tearing of those ligaments on the lateral side, and then of course we can have that deltoid ligament reconstruction for medial sided injuries. We'll get into Lisfranc ORIF. Lisfranc is a ligament in the foot, and sometimes that can be torn. They have to go in to repair that and create some bony congruency there. And then syndesmosis injuries, which are usually a result of medial or I should say pronated ankle sprains, as opposed to your typical ankle sprain, which is like a supination sprain. So again, post-operative considerations, this is just like the knee and the hip, right? You got to recognize what your weight-bearing status is, your range of motion restrictions and limitations, and what immobilization status the patient has. So does that mean they're in a cam walking boot, or are they in a cast? Hopefully you're not seeing them while they're in the cast, but there's some things you can do if they are, right? You obviously can't focus on the foot and ankle complex, but you can do things like open chain hip exercises, core strengthening, maybe get a spin on the bike, get some blood flow going to promote healing and things of that nature. But typically I don't see patients while they're still casted. So what is a cam walker boot? Well, it stands for controlled ankle movement. And ironically enough, cam, just like a camshaft or something in a car, right? It's kind of got that curved edge. It almost is like those Skechers shoes that basically have that rounded bottom, that all that marketing came out a few years ago, that people will walk better and healthier and things like that. So it's kind of got that rounded edge on the bottom. This stabilizes the foot and ankle and allows for weight bearing. If you notice, they're also very stylish. We can see David Beckham looking pretty fly. He has his high top boot actually, and at the top there of his boot you can see he has a little pump, just like those old Reebok sneakers. You can pump these up and it creates a form-fitting kind of insulation around your foot, and what that does is just further immobilizes and stabilizes the foot and ankle and prevents it from moving. The big thing here is, does it fit right? I quite often get patients who have boots and their toes are sticking out of the edge. They don't fit right. They're not wearing them right. So if anyone has a boot and you're listening to this lecture, bring it in to our lab on Thursday. Maybe we can go over some of the fitting of those. So if we continue on here, let's dive into our bony surgical procedures. The most commonly fractured areas of the foot and ankle are the distal tibia, or the medial malleolus, the distal fibula, or the lateral malleolus. There can be a combination of the two, so like a distal tib-fib fracture, we call it bimalleolar fracture, just meaning both malleoli. And then if the distal tib, fib, and the posterior aspect of the tibia are fractured, we call that a trimalleolar fracture. As far as the foot is concerned, you can have stress fractures and outright fractures even to the talus, as well as the calcaneus, and that is called a lover's fracture. And for anyone who can tell me in class why it's called a lover's fracture, I'll see about giving you some extra credit. I know Dr. H says I don't have the ability to do that, but still look that up, and we can go over that, why it's called a lover's fracture. And then the base of the fifth metatarsal, or a Jones fracture. And that's just called a Jones fracture because I guess that's the doctor or physician who decided to name it that. When you twist your ankle, if you twist it severely enough, you can fracture bones, you can tear ligaments, and usually these sprains that turn into fractures are predictable in how the injury occurred, right? The mechanism of injury has been studied pretty intently. So there's three types of what we call the Danis-Weber classification system. Type A is the least severe, all the way up to type C, which is the most severe. But type A is basically your typical ankle sprain gone severely wrong. It occurs below the level of the syndesmosis. The syndesmosis in this case is basically the point where the tibia and fibula come together distally. So it happens below that level. It's the result of an adduction force on a supinated foot. And I like these pictures demonstrating because it goes through the stages here. The first picture on the bottom left, you can see that foot's going into supination and the forefoot's going into adduction. If it continues to progress, stage 1 is tension on the lateral collateral ligament, results in ruptures of these ligaments or an avulsion of the lateral malleolus below the syndesmosis, like we already mentioned. Stage 2, if it continues to go, we get compression forces on the medial malleolus, so there's an oblique fracture that could occur there as well. Typically there's no trauma to the posterior malleolus or the distal posterior tibia. But as you can see there, they'd have to go in and do an ORIF, and we'll show you some pictures of that later on. If we move on to the Danis-Weber classification for type B, this is a transsyndesmotic fracture, so it's right through where the distal tib and fib meet, and it usually has a partial and less commonly total rupture of the syndesmosis. It's caused by a supination and external rotation mechanism. So the foot's supinated, but the talus gets kind of spun into external rotation, or the forefoot rather gets turned into external rotation, which causes basically snapping to occur. It's the most common ankle fracture and accounts for as much as 80% of all ankle fractures. That's done by epidemiology study by Stufkins. So let's run through the 4 types here, and basically for testing purposes, what I want you to know for these isn't necessarily all the stages and what each one is, but I want you to kind of know the mechanism of injury for each. So as you know, the previous one was supination and adduction. This one is supination and external rotation of the foot, or abduction, I guess. So stage 1 is rupture of the anterior syndesmosis, and that's numbered there. You can see that distal tibiofibular ligament, I guess, is being torn. Stage 2 is oblique fracture of the fibula. This is what a true Weber B fracture is. Stage 3 is a rupture of the posterior syndesmosis, or fracture of the malleolus tertius. And then stage 4 is an avulsion of the medial malleolus, or rupture of the medial collateral bands. So this is one that you would see a trimalleolar fracture result from. And then our type C. This is a fracture above the level of the syndesmosis. Is usually there's a total rupture of the syndesmosis with instability of the ankle. Sometimes people call these high ankle sprains. If they progress too much, it can fracture, right? Because some of the force gets generated up through the foot, through the ankle, up through the syndesmosis, and can cause a fracture actually higher up on the fibula. This is caused as a result of external rotation force on a pronated foot. Stage 1, avulsion of the medial malleolus, or ligamentous rupture. We can see that in that second picture there. Stage 2, if that continues to externally rotate, there's rupture of the anterior syndesmosis. Stage 3, the fibula fracture occurs above the level of the syndesmosis, and this is what we would consider a true Weber C fracture. And then stage 4, there's avulsion of the medial malleolus as well as maybe the posterior malleolus. So there you have it. Those are our 3 types of ankle sprains gone wrong. And again, I just want you to know kind of the mechanism of injury for these classification types. So what do we do when someone's injured this badly, right? I mean, as soon as a bone fractures, not only are there shards of bone going everywhere within the soft tissue, we want to make sure that they're stable enough to walk. We want to make sure their pain's managed and that sort of thing. So when I respond to like on-field injuries and this happens, the first thing we do is air cast them, right? Because we want to stabilize that joint as soon as possible. And surgery actually tries to do the same thing. It tries to restabilize an unstable joint or a fracture. It's pretty common. We've gone over this a lot with other parts of the body. These ORIF, or open reduction internal foot fixation, is all about creating stability once again and allowing that bone to approximate and heal. So medial malleolus, what do? They can be as simple as taking 2 screws into the edge there. That kind of reminds me of the medial epicondyle seen in pictures. Or lateral malleolus, sometimes they'll use a plate with screws. So I want to give you a couple of options there. And it really depends on the type of fracture. So in the lateral malleolus picture, it looks like that might be more of a kind of a spiral fracture. So it makes sense to use a plate to secure that a little more tightly. When we think about a bimalleolar fracture, we just are basically doing both procedures in one, right? We're securing the medial malleolus and the distal fibula, And then a trimalleolar fracture, I pulled up a CT scan here. This is looking at the foot and ankle from the side view, I should say, or through the sagittal plane. And you can see that that posterior distal tibia has been fractured, and then what the subsequent ORIF looks like there. One thing to note is if you look at the length of the screws in that picture, you can see how they almost overshoot the edge of the tibia there. So just know if you see that on an x-ray, and not only does this patient have an extreme pain from this this procedure and the subsequent fracture that occurred previously to cause it, but the screws poking through may be causing some like undersided soft tissue damage, but usually they do okay. Here's that trimalleolar fracture, just in a little more depth. Basically, this refers, as we previously mentioned, to two anatomical malleoli, and as well as the posterior distal tibia. If you see the picture above labeled C, that's kind of another representation of CT scan. And then if you look all the way over to the picture on the right, that kind of computer-generated CT scan, you can see all the fractures. You can see the medial sided one. You can see the posterior tibial fracture, and then of course the fibular fracture. It's a pretty cool image that they can do with the foot and ankle complex these days. That picture also gives the surgeon a little better representation of what he's trying to approximate. It's very, very helpful imaging. So rehab considerations. What do we do with these patients? Well, just like every surgery, a lot depends on the severity, the location of injury, and any concomitant procedures or injuries. So let's say someone came in for an ORIF. Well, they could have had some concomitant injuries to ligaments or tendons or whatever, and had surgical interventions on that too. So you want to make sure that everything else is taken care of as well. But generally speaking, this is kind of the phase we go through. Phase 1, which is our max protection phase, is from week 0 to 2. Patient's going to remain in their splint. You're going to work on pain modalities. Basically, they're non-weight bearing for 6 weeks, so they're even sometimes not only in a splint but also in a cast. I don't usually see these patients till about 6 weeks. But phase 2, we're going to work on range of motion. They're non-weight bearing still in their high top boot. It's locked, not allowing for any motion. You're going to work on general activation of dorsiflexion and plantar flexion, but no inversion or eversion, and that makes sense because if they had an ORIF on the medial malleolus or lateral malleolus, we don't want to stress that too much before 6 weeks. So we know 6 to 8 weeks typical bone heals, so if they've got a plate or screw running through their bones, we don't want to stress that too intently. Phase 2 continued. Now we're looking at the second half of phase 2, which is week 6 through 9. This is typically when I see my patients post-op. You're going to start initiating weight bearing. You're going to progress to weight bearing as tolerated in their boot. And then starting at week 7, you can initiate our gentle inversion and eversion. Week 9, so after 8 weeks, they get fitted for an ankle brace. We call it an ankle stability orthotic or an ASO. And then we initiate gentle strengthening. We open up their boot, we begin stationary biking, etc. Phase 3 is when we can really get going with these guys. They're out of their boot, they're into their lace-up ankle brace. You can progress their weight bearing. You want to get them to full range of motion, full strength. This is when you do a lot of weight bearing stuff and a lot of manual therapy and a lot of stuff to get them back. If they have access to a pool program, jogging in the pool is really cool. I didn't mean to rhyme just then, but I guess I did. So, phase 4, advanced strengthening. This is weeks 12 through 16, months 3 to 4. You're going to continue with end range stretching. Make sure they get their range of motion back, because if they're an athlete and they're progressing back to sport, you really want to make sure there's no side-to-side differences there, as well as with strength training. Proprioception is huge in these guys. You know, they obviously sprained their ankle for a reason. We're going to go over that lateral ligament reconstruction later. And there's also an article I'm going to put on your course shell that I want you guys to read regarding rehabilitation and proprioception following ankle injuries. It's a very good read, very good intervention ideas. Initiate jogging at around 10 to 12 weeks based on their progress. If they're doing really well, if they're not having side-to-side differences, if their Y balance test looks good, if they can kind of, there are some functional tests that if you want to learn more about, I think the sports elective class is gonna be much more up your alley if you want to know how to get people back to doing those higher level activities like jumping and running and sprinting and cutting and things like that. We'll go over that then, but it's a lot of functional discharge testing that I do to make sure people are ready to progress back to sport. And then based on, it says per physician release, but where I work, the physicians rely on me to release the players back to play, and it's kind of an open communication between me and the surgeons and the athletes or the patients when we can return to certain things. And sometimes it's pressure, but a lot of times the surgeons just want to make sure that the patient is, based on our recommendations, is ready to go, because we do see re-injuries happen with patients who don't finish out therapy. Let's talk about ankle osteoarthritis. This is any weight-bearing joint. OA can run rampant. We know about the hip, we know about the knee. The ankle is a little less common one as far as what we go into in school and what you even might see out on the public. But anyone who's had an injury to the ankle prior is at increased risk for ankle arthritis, just as we learned about in the knee. So to treat ankle osteoarthritis surgically, there's basically two things that we can do. One is called an ankle arthrodesis, and we'll abbreviate that by AAD, and then our total ankle replacement or arthroplasty, which we'll just abbreviate as TAR, and that's how they typically do it in our references. They'll have it indicated as TAR, and those are the two major surgical treatment options for the ankle. There is ongoing discussion in the orthopedic community whether an ankle arthrodesis, also known as an ankle fusion, should be the treatment of choice for end-stage OA. Basically, the reason there's discussion is because the total ankle replacement is claimed to restore the ankle kinematics, which is important. On the other end, the arthrodesis affects the kinematics of that tibio-talar joint. And because it affects it, not restores it, it restricts your gait patterns. It restricts your motion. After ankle arthrodesis, your mobility of the foot relative to the lower leg decreases by 70% in the sagittal plane. So you're talking about trying to walk through the gait cycle at 30% potential. Not very good. These guys hobble around. They walk with a constant limp. They have excessive toe out so that they can clear the toes. It's not a great scene. But total ankle replacements are a little newer than maybe a total knee or total hip. There's not a lot of expert surgeons on total ankles. It's a complicated procedure. The outcomes aren't great, and I think that has to do with the fact that the ankle and foot complex is just so in depth. The kinematics behind it, basically the kinesiology behind the foot and ankle is just so complex. How do we recreate that? And I think that's why you see a lot of surgeons turn to this, which is our arthrodesis. And in this case, this is called a triple arthrodesis, where they fuse the the talus and the distal tib fib to prevent any motion there at the talocrural joint. Sometimes those screws will drive all the way into the calcaneus as well, sometimes into the cuboid. Anywhere this patient is having severe arthritis, they will drop a screw in and prevent it from moving. That does not look fun, and I can tell you the patients that I see with this, they have pain for a long time, even after the 6 to 8 weeks of supposed healing time. They're not allowed to weight bear for a very long time. I would much rather see a patient with a total ankle arthroplasty. And this depends on your patient. I'm not going to say that arthrodesis are much worse. I think it depends on the patient for sure. But if I had arthritis in the talocrural joint I would much rather have a total ankle to maintain that mobility rather than fuse everything. So our total ankle replacement can have a positive impact on our patients' lives. Its benefits lasting as long as 10 years, and this was judged in a study based on patients' improvement in pain and function as well as their improved gait and increased range of motion. There's a pretty cool study by Butler. He examined single leg balance ability in 234 total joint arthroplasty patients. Of those 234, 75 were hips, 65 were knees, and 94 were ankles. So it's a little more biased on the ankles. And he basically at 12 months following their surgery, he tested them into a single leg stance. All he said is, I want you to stand here on your surgical side for 10 seconds with your eyes open. If you could do that, you passed the test. If you couldn't do that, you failed the test. Following 1 year, total hip patients were able to complete the test, 63% of that 75 patients. And then our total knee patients, 69%, roughly 70% of the 65 total knees could do it. But look at the total ankle arthroplasty. Only 9% were able to stand on their leg for 10 seconds. So out of 94 patients, we're talking 9 patients, maybe 8 patients were able to stand on their affected side for 10 seconds or greater. That's absolutely terrible. Now, I don't know if that's due to the patient population that receives total ankles or if that's due to basically physical therapists as a profession not doing a good job treating proprioceptive qualities, but I know that number has got to go up or we're looking at terrible outcomes for our patients. I would hate if my patient, only 1 out of 10 patients left with the ability to stand on one leg for 10 seconds. That's pretty bad. So, pretty cool study. Opened my eyes to some of the things I need to do in my clinical practice. Hopefully you guys too when you get out on your clinical rotations. So what's the better option for the management of ankle OA for the active individual? And that's really what I want to look at, is what the active individual will want to get back to. Shu et al. Looked at 41 patients. 21 were ankle arthrodesis, 20 were total ankles. They were examined at basically the 3-year mark, 34.5 months. These patients, they looked at outcome measures, which one was the UCLA score and one was the AOFAS, which is basically a foot and ankle subjective test, and they compared between the two treatment groups. Preoperatively, the ankle arthrodesis group, 86 participated in sports. The total ankle group, pre-op, 76% participated in sports. And then they looked at them post-operatively at that 3-year mark. Both groups, 76% were active in sports. This was a significant change and drop in participation from the ankle arthrodesis group. But what they did see is that when you compare the two groups, there's no significant difference concerning activity levels, participation in sports activities, or functional outcome scores. So it seems like both surgical procedures do a pretty good job at getting people back to being relatively active. Daniels et al. Looked at many more patients, 388. 281 were total ankles, 107 were fusions. He followed them at 1.2 years. He looked at some of the similar things, right? An ankle score, at their pain levels, disability scores, so on and so forth. Basically, his conclusion was that intermediate term, or at that 1.2 years, clinical outcomes of total ankle replacements and ankle fusions were comparable in a very diverse cohort in which treatment was tailored to the patient's presentation. Rates of reoperation and major complications were higher after ankle replacement, and that's just due maybe to things like infection or components breaking and things like that. So we'll move into our Achilles tendon rupture. I just want you to take a moment and examine the picture on the right. I know it's a little gruesome. I apologize, but you'll notice where the incision is. This is actually looking at the foot and ankle. The heel of the patient is at the top. The Achilles is where you would expect it to be, however, not attached. You can see the 2 loose ends there. That's a mid-substance complete rupture of the Achilles tendon. And barring any change in schedule, you will meet this patient today, and I'd be very, very happy if you guys were open and participating and asking questions to this patient. I've been treating her for about 2.5 months now, and we'll get her in and we'll get her rolling with you guys today. She's doing great, by the way. The incidence of Achilles tendon rupture is 3.26 out of every 10,000 people. Males in their 30s are most injured, and what makes our patient that we'll talk to today unique is that the male to female ratio of Achilles tendon rupture is 20-1. So not great odds for a woman to rupture. It makes it more interesting when we ask her about her injury. Most commonly injured in what we call the watershed area. This is an area of poor vascularization. It's approximately 3 to 6 centimeters or 2 to 3 inches above the insertion of the Achilles tendon on the calcaneus. As you can see, this is roughly exactly where our patient ruptured the Achilles. In this area, it's called the watershed area because perfusion is poor, especially during contraction and stretching of this area. So if you think during times of eccentric contraction, where our Achilles or basically our quad, or excuse me, our gastroc and soleus complex are eccentrically contracting and lengthening, perfusion is especially poor, and I think repetitive eccentric landing can lead to something like this. A lot of times too, it's really just bad luck, bad angle, overuse. Could also be due to oral or intratendinous injection of corticosteroids. It's been known to cause tendon ruptures. They don't do a lot of injections into the Achilles tendon area because of this. So yeah, take a look. Pretty gruesome. There's a lining of tissue that actually covers the Achilles tendon called the peritoneum. It's the same thing that covers the knee. And I bring that up again because surgeons like to repair that as well, just to create some more stability and reestablish better anatomical relationships. The presentation, if you basically respond to someone who's down in pain and holding their lower leg, obviously you'll think probably an ankle sprain first, but this patient's going to have pain, inability to bear weight. They're going to tell you there's a clear popping sensation following an episode of activity during which they sustained a forced dorsiflexion moment or from a forceful eccentric contraction of the gastroc soleus complex. The patient describes being kicked, shot, or even bitten on the heel. Frequently following injury, there's a visible defect in the Achilles tendon. You can also palpate that. There's a lot of swelling, but the Thompson squeeze test or the Thompson test is very good both in its sensitivity and specificity at diagnosing an Achilles tendon tear. The squeeze test is essentially you have the patient lay prone, you squeeze their calf, and if their foot plantar flexes, then their Achilles tendon is intact, right? But if you squeeze it, put tension on the gastroc soleus complex, and there's no plantar flexion moment at the ankle, the test is positive for an Achilles tendon tear, and that's because the tendon's ruptured. And as you squeeze that calf muscle and there's no plantar flexion, we know that the tendon's ruptured because it's not generating that force all the way down to the foot to create that motion. We can go over that test in lab. You probably already have. As far as diagnosing this, if that wasn't enough, Doppler ultrasound is being used to diagnose because it's much cheaper than getting a patient seen for an MRI. And I think it's not the gold standard. MRI is still the gold standard, but this is very reliable. It's 100% accurate, very sensitive, very specific to correctly diagnosing an Achilles tendon rupture. So what do? They go and repair these. And there's several different surgical techniques and stitching techniques, and it all depends on your surgeon's comfort as well as maybe where the tendon is torn In the younger, active patient, it's probably going to be a mid-substance tear. In the older, more sedentary person who has like a Haglund's deformity on their heel and heel spurs and things like that, it's probably going to be repaired more at the teno-osseous junction there, where the tendon meets up with the bone. There's several repair techniques. I'll let you look at them. There's an article I'm going to put in there about these repair techniques where I actually got these images from. The great thing about all these repairs is that a systematic review saw that there's a low re-rupture rate, anywhere from 1.4 to 2.8%. So that's pretty good. That's pretty good. That's better than our ACLs that we're thinking that they're more on around the 4% mark of re-rupture, both on the same side and contralateral. This is about half that, which I'll take. Conservative care has a reported re-rupture outcome of around 12 to 17%, and believe it or not, a lot of patients, depending on the severity of their tear, say they have a grade 2 tear, so it's not completely torn, they might attempt conservative rehab and let scar tissue form there. Now, it does have a higher risk for rupture. It also carries the risk of basically scar tissue formation and loss of strength. So if scar tissue takes place of where the tendon was torn, you don't have any more contractile tissue, or I should say the elasticity that the tendon provides if that scar tissue forms in its place. So you lose strength, you lose range of motion. Based on the re-tear, re-rupture rates, I would probably elect for surgery if it was my Achilles tendon. So let's look quickly here at post-op considerations. You can do one of two things. You can listen to me for the next couple of minutes, talk about this, or you can pause it and look through it on your own. But phase 1 is our early protection phase. Patients are required to wear their boot while sleeping. They may remove it only for bathing and dressing. You got to remember they're going to have an open incision on the back of their leg, so you don't want to soak in any bathtubs or introduce it to water for risk of infection. And you definitely don't want to push dorsiflexion range of motion. If you push dorsiflexion range of motion and you rupture the newly sewn together surgery, you're going to be in a world of trouble. So I'm not even, with our patient here, she's 3 months out now, we're not even stretching into dorsiflexion still. That's the big thing I want you to take home, is do not push passive dorsiflexion. Weeks 0 to 2, they're in their splint and non-weight bearing with crutches. Weeks 2 to 4, you can begin protected weight bearing, approximately 50% in their boot. In their boot, they're going to have a 3-block heel lift. So essentially, it's almost like 3 inches of a heel lift inside of that cam walking boot. And this is to keep your patient into a plantar flex position while they're bearing weight. As you progress through phase 1, phase 2, you can start removing some of these heel lifts. And by week 6 here, it says phase 2, gait and endurance phase, may gradually remove your heel lifts. And at this time, emphasis is on gait training. You're going to do weight bearing as tolerated in the boot. You're going to continue your modalities, initiate gentle slow, dorsiflexion. It says stretching. I let them do active range of motion. I don't push anything passive, especially not to end range. Here's when we can start our seated proprioceptive exercises like BAPS board or rhythmic stabilization, some PNF type patterns. Get them on the bike, get them spinning, get their blood flow going. In this phase, you're going to try to regain their full range of motion and their open kinetic chain strength. By phase 3, this is our strength and proprioception phase. This is where the patient that will be coming in to see us in our lab, this is the phase that she's in. So if you want to ask her some questions about some of the things we're doing in therapy, go for it. And even up in the first 2 phases, what we were doing in therapy. If they look good, and I mean that, I say if they look good, meaning you know they're good through some functional testing, you can start beginning a run-walk program. And what we do is, if they can have normal gait and they can have a single leg squat against resistance for 90 seconds, then we can start doing a little bit of impact stuff. And what I'll do too is get our patients on the horizontal leg press machine, and it's kind of like a sled leg press that we can work on jumping in an anti-gravity, or excuse me, a gravity eliminated position, so that we can take away, some of the force that gravity puts on our patient through weight bearing and things like that. If by the end of that 16-week they're looking great, you can progress them to phase 4, which is our return to sport phase. This is about the time that Kobe Bryant came back. I think he was at like 3.5 or 4 months. But you understand, Kobe Bryant has probably 2 or 3 physical therapists working on him at least 10 hours a day for 3.5 months. Yeah, he's going to come back and faster than most people, not to mention he's a freak beast. Anyways, to get back to their sport and to clear them to play, I like to pass them through the sport cord test. They have to run with normal gait. They have to demonstrate symmetry with a functional hop testing, and then what's not there is our Y balance test, which I'll put them through, which is a huge indicator of future risk or injury if they can't pass that. Let's get into the lateral ligament injury. This is caused by our severe ankle sprain. We went over the Danis-Weber classifications earlier. We won't rehash on that, but this would be more that type A Danis-Weber. A couple of things about ankle sprains I want you to know. Females have a higher incidence compared with males. Children, higher incidence compared with adolescents. Adolescents more than adults. And then if you play indoor or court sports like basketball or racquetball or tennis, you're at an increased risk. So if you're a female basketball player who's like 8 years old, you're destined to sprain your ankle. At least that's what this data is telling me. So just look out for that. Grade 3 ankle sprains, surgery is typically indicated because you've lost stability. So we got to reestablish that stability. The repairs or reconstructions they do, basically they're called Brostrom repairs. The Brostrom repair is a repair of the ATFL, or the anterior talofibular ligament, as well as the calcaneofibular ligament. All they do is they stitch those back together. You're in a time period of protected weight bearing and things of that nature. They did update it, the Brostrom Gold repair. It's similar, except now the surgeon will take some of the extensor retinaculum to reinforce that ATFL, or maybe the ATFL is shredded beyond repair and they need some sort of soft tissue structure to reestablish the stability at that joint. So they take the extensor retinaculum and repair it back to the bone there. Or they can do a graft, and at this point that they take autografts or allografts from cadavers. Well, they'll take an autograft. They can take the hamstring. Typically, what I see in the ankle is they'll use allografts, just because they don't want to create another surgical site, another injury to the ankle, and those usually heal up pretty well, even if it's a reconstructed graft from an allograft. Let's talk about our Lisfranc joint and Lisfranc injury. So this is typically done when the foot is in a plantar flex position and there's extreme weight bearing gone through it while the toes are in an extended position. This kind of creates this pile driver effect on these bones, and because the second metatarsal bone is usually the longest in most people, that's usually where the force is driven through, and it butts up against the first and second cuneiform, and essentially dislocates. And most recently, Des Bryant had this injury occur last season, and they go in and they put a screw in there, hopefully reestablish some congruency. But Lisfranc, it's kind of a weird name, right? It's the joint complex between the midfoot and the forefoot, and this goes all the way across all the midfoot. But it's named after Jacques Lisfranc de Saint-Martin, and I hope I said that right. He was a French army field surgeon in Napoleon's army back in the 1700s, And he described an amputation of the forefoot through the tarsometatarsal joint. So as Americans are studying this in the medical profession, they kind of deem this area the Lisfranc area of the foot. Here are the classifications of injuries. So stage 1, Lisfranc ligament is sprained, and that's basically between the first cuneiform and the second metatarsal. If that is sprained and there's no diastasis or separation, is another way to say that. If there's no separation and everything still looks congruent, that's a stage 1. It's usually just sprained, they'll leave it as is. There's pain, but they'll take an x-ray, and if there's no separation, they don't consider surgery. They try to let it heal. A stage 2 is when you get a 2 to 5 millimeter diastasis or separation between the second metatarsal and the first cuneiform, and this is definitely indicative of a ruptured Lisfranc ligament. It's a stage 2 because there's no arch height loss. And what I mean by that is there's no longitudinal arch loss in height. Stage 3, ruptured Lisfranc ligament, again 2 to 5 millimeters diastasis. This is when the bone actually separates and then drops, so you have a loss of arch height. For some reason that's hard to say, arch height. There's a loss of longitudinal arch height, and you can tell because the patient's foot will be nice and swollen, black and blue like this. A bruise on the underside of the foot is the hallmark sign for a Lisfranc injury. So if you respond to an on-field injury and patients complain of pain in their forefoot, and you look around, everything looks okay, don't forget to check the bottom of the foot. This is a pretty good indicator that something's happened at that Lisfranc ligament. So as far as surgery goes, I try to make this a very simple diagram and picture on the right. You can see the injury there in the forefoot, and you can also see how they would reestablish congruency. That's it in its simplest form. Depending on the injury, they can use plates and screws and all that sort of thing. Existing protocols for post-op treatment of Lisfranc injuries emphasize non-weight bearing for 4 to 6 weeks. We can go over a couple studies here to see if that's still recommended, but Brinsden reported an average time to return to regular activities of 6 months. Similar study by Curtis reported an average time to return of 4.25 months. You can see the low patient number here. And then in a retrospective study, Nunley and Vertulo, who are big in the Lisfranc world, reported an average time to return of 3 to 6 months, or 3.6 months rather. So we're looking at around 12 to 14 weeks, it seems. But more recently, Wagner et al. Found that patients were encouraged to bear weight as tolerated after the 3rd post-op week. Now this goes against our traditional thinking that bone needs to heal 6 to 8 weeks to heal. Well, I think the thought here is that nothing's really fractured, right? That small tiny ligament that maintained stability was torn, and now we got a pin going through it reestablishing that stability. So maybe we don't need to non-weight bear for 4 to 6 weeks. Maybe we can start weight bearing at 3 weeks, because basically to the patient's tolerance, and see if they do better. So that's what they looked at. They initially used a cam walking boot or stiff-soled shoe, while gradually moving into a more giving shoe. Patients in the study were able to return to their normal activities before 2 months, so we're talking less than 8 weeks. This could suggest that early weight bearing in rehab could be more significant determinant of Lisfranc injury recovery regardless of the chosen treatment regimen. And I think when we look at a high-level athlete like Des Bryant, who I'm a Redskins fan, and I was happy he was out for several weeks. I don't wish injury on anyone, but he was out. They were expecting 7 weeks for him to come back. They were going to play the Redskins, I think, on week 8. So I was praying that his rehab would be delayed. It was. The Redskins beat him. He came back 10 weeks later. So he was 2.5 months, but he is like an extremely talented, athletic individual. He needs that joint to work perfectly for his profession. So long story short, those pro athletes can get back pretty quick as well. I think that does it for our foot and ankle post-op section. There's a tremendous amount of more information that we can go into. If you do have questions or concerns or know of friends that have weird surgeries and want to find out more about it, let me know. I'll do my best to get you guys some references, some journal articles, etc. Again, I would like you guys to make sure that you're prepared for our patient that's coming in today, and have a lot of questions. It's going to be really cool, really fun. Maybe we'll do some physical therapy type stuff as far as interventions go inside of, or rather while she's here in the lab, and maybe you can get your hands on a real patient, and we'll go from there. But thank you guys again for your attention. I really appreciate your time, and sorry I got this lecture up a day or two before, but we will go into as much detail as we need to shore up any questions that you might have. So thanks a lot.